Bertrand, any thoughts on active surveillance?
So
how is that in Europe and
active
elsewhere?
surveillance actually has become, I would say, the standard of care of high-risk localized disease. And the missing link was getting confidence in the prognostic value of your biopsy. Because the problem is that everybody speaks about prostate biopsy and doesn't understand that there is a huge quality control issue around biopsy. And it's very interesting to see that both continents have solved the quality insurance differently. In the US by incorporating genetic tests, MDXL, Oncotype DX. We don't have these in Europe yet because we have a value-based system and the company failed to make the value-based estimation. Where in Europe, MRI has become really the adjunct to a high PSA. So now, at least a country like mine, France, it's getting more an exception to have a biopsy without an MRI. And so suddenly, incorporating MRI from the work of a UK trial like PROMISE Precision have shown that basically a 12-core, blinded biopsy, it's like, tossing a coin. So now we're getting more confidence in the biopsy. So meaning that we have like a safety net and we can now start to monitor patient with MRI and get rid of further biopsy. And very interestingly in Europe, it's opening a totally different field, which is those with identifiable cancer. So that's really opening the field for focal therapy, which is very rapidly growing, especially with two technology, the 2CAT technology and the HIFU technology. And what's happening now is that we're bringing this strategy to the intermediate risk. So meaning today, if you're like a 55 years old, you got a PSA at 5, you've got one single Pirates 4 lesion, and it's a Gleason 3+4, people are asking, why do you want to get rid of my prostate? Why not try to just... So we're building a whole world of what I call enhanced active surveillance, meaning selective eradication of cancer. And in Europe, it's getting very, very, so that to the point now is, how can we get better use of the MRI resource, which are still limited. But clearly, you see that the trend today, the standard of care for low risk has become active surveillance.
And we certainly do that kind of focal therapy approach in kidney cancer,
exactly,
in other settings. So it makes sense. It is a little bit of an extrapolation from the active surveillance to include that piece, but it certainly goes along with the tenets of how we manage early cancer in other settings.